Right. So a very good morning, everyone. Am I audible to everyone? Yes. So am I audible and visible? Okay. So thank you very much, Soumya. Right. So a good morning to all of you. So in this session, I'll be discussing the electrolyte abnormalities. In the electrolyte abnormalities, I will be discussing the disorders of potassium. And in this session, I will be able to discuss only the hyperkalemia part, not the hypokalemia. In this session, I'll be discussing only the hyperkalemia. Right. So before starting ahead with the session, let me just give you the thought for the day. Right. So this is a very, very important quote for the students who are preparing for the upcoming entrance exams. See, please don't wake up with the regret of what you couldn't accomplish yesterday. Wake up while thinking about what will be able to achieve today. This is very, very important because most of us, like who are preparing for the entrance exams, we will keep a plan to complete these number of topics for that particular day. And once we are not able to complete the topics what we have kept in the plan for the day, we feel very much regretted, right? We feel very much sorry. We feel little depressed as well. And in that particular thought process, we will also disturb our next day as well. Please don't do that. If you are doing that, definitely you will be disturbing your next day as well. So what you have to complete now and how to achieve the yesterday's incompletion, that is what you should be your thought process whenever you get up, when you are not able to complete the yesterday's topics. Okay, so don't wake up with the regret of what you couldn't accomplish yesterday. Wake up while thinking about what will be able to achieve today, right? So having said this, let us start with the session. Now, what will be the overview of the topic? See, in this session now, in another 1 hour, I will be discussing what is the cause of death in hyperkalemia. See, why are we discussing hyperkalemia? We are discussing hyperkalemia because the individual may die. What is the cause of death? How can you prevent that? And what are the etiologies of hyperkalemia? What do you mean by pseudo hyperkalemia? And what is cotopyrophagia? Then clinical consequences of hyperkalemia, ECG abnormalities, management, and as well as some multiple choice questions we will discuss at the end of the session. Now, coming to the first important question, right? Coming to the first important question, what is the cause of death in patients with the hyperkalemia? Can anyone answer? Systolic arrest, diastolic arrest, respiratory failure, congestive cardiac failure. What is the cause of death in hyperkalemia? Any one of you, please answer in the chat box. Very good. So, right. So Srinivas Balaji was the first person to answer. Then Pavitra Durai, you are also the correct. The answer is the diastolic arrest. Now, why there will be diastolic arrest? What is the mechanism for the diastolic arrest in case of hyperkalemia? All that I will be discussing now. Okay. Now, so if you take the normal potassium levels, right? Yes, Srinivas Balaji, can you tell me how much is the normal potassium levels? Any one of you, in fact? The normal potassium levels, they are around 3.5 to 5 milliequivalents per liter. Right? That is the normal potassium levels. Now, one second. Yes. Right. Now, after having said what is the normal potassium levels, you need to know what are the etiologies which will cause the hyperkalemia. What are the etiologies which will cause hyperkalemia? Now, first of all, before going ahead with the etiologies causing hyperkalemia, please tell me potassium, majority of it, is it intracellular or is it extracellular? Large quantities of the potassium, very good. So the potassium, let me tell you, it is an intracellular ion. What about sodium? What about sodium? Very good, Vishnu. Sodium, it is extracellular ion. Now, what are the etiologies which will cause the hyperkalemia? What are the etiologies which will cause hyperkalemia? There are two important etiologies. Number one, because of transcellular shift right? Because of the transcellular shift, there can be hyperkalemia, and due to impaired renal excretion. These are the two important causes for hyperkalemia. Now, you take the impaired renal excretion. Now, please tell me, what are all the sites of renal tubule where the potassium is being reabsorbed? What are the sites of renal tubule where the potassium is reabsorbed? Yes, anyone? Proximal convoluted tubule. Very good, Lakshmi Priya and Vishnu. Proximal convoluted tubule is the site where the potassium is being reabsorbed. These are the two important causes. One is transcellular shift and the other one is the impaired renal excretion, right? And if any of the students, you are unable to write the content what I am teaching, immediately after the class, I will be sending you the PDF also. So don't worry whether you are able to write or not able to write, I will be sending you the PDF. Now you should know that, for suppose, if the source of hyperkalemia is unclear, then that means like whether the hyperkalemia is due to transcellular shift or whether hyperkalemia is due to impaired renal excretion. If you are not clear, then what you have to do? You have to do a spot urinary potassium levels. Now, for suppose in the right, for suppose in the if the urine potassium, if it is more than 30 milliequivalents per liter, what is the etiology you will suspect? If the urine potassium, if it is less than 30 milliequivalents per liter, what is that you will suspect? Okay, now please tell me, if the urine potassium is less than 30 milliequivalents per liter, what is the etiology of hyperkalemia? Any one of you? Urine potassium is less than 30 milliequivalents per liter. That means no. It is impaired renal excretion. Right? Impaired renal excretion. See, okay, you take the kidney, right? The function of the kidney is that, one of the function of the kidney is that the excess potassium, whatever is there in the body, is excreted out through the kidney. If there is renal failure, either you take acute renal failure or chronic renal failure, the kidney is not able to send the potassium out. And that is what is nothing but your impaired renal excretion. And in such clinical scenario, the urine potassium will be less than 30 milliequivalents per liter. Now, please tell me, what are the sites through which the potassium is excreted out, or what are the sites through which the potassium is secreted and excreted out? Any one of you? Yes. What are the sites within the renal tubule where the potassium is secreted and excreted out? Very good, Pavitra. The answer is the distal convoluted tubule. Right? The answer is distal convoluted tubule. Right? Yes. Very good, Lakshmi Priya. Even the ascending limb of loop of Ellie, but predominantly it is distal convoluted tubule. Now, Pavitra, can you tell me which particular hormone is responsible for secretion of potassium at the distal convoluted tubule? Which particular hormone? Very good, Sangeeta and Pavitra. The answer is aldosterone. right? The answer is aldosterone. So aldosterone, what it will do, it will cause sodium and water retention, potassium and as well as H+A excretion. Now, for suppose, if the urine potassium is more than 30 milliequivalents per liter, causing hyperkalemia, then you have to suspect transcellular shift. Right? Then you have to suspect transcellular shift. So that is about the source of hyperkalemia if it is unclear. Next, followed by that, you need to know what do you mean by pseudo hyperkalemia. Right? You need to know what do you mean by pseudo hyperkalemia. See, what is pseudo hyperkalemia? Pseudo hyperkalemia is that where there is a hyperkalemia in the blood sample. Right? There is hyperkalemia in blood sample. That is ex vivo. But not in vivo. Right? Actually, there is no hyperkalemia. But in blood sample, whatever has been collected, there is hyperkalemia. Now, can anyone tell me what is the reason? Yes. Can anyone tell me what is the reason? Very good, Sangeeta. Excellent. Super. So the leading cause of this particular condition is the potassium release from traumatic hemolysis. Right? Potassium release from traumatic hemolysis during the venipuncture. Right? During the venipuncture. Right? During the venipuncture, if there is lysis of the RBC, if there is hemolysis, then the potassium is released from the traumatic hemolysis causing hyperkalemia. Right? Now, one of the reason for your pseudo hyperkalemia is traumatic hemolysis. And the other reason is, like for example, if potassium is also released into the circulation from muscles while clenching the fist, right? See, you are taking the, right, you are doing the venipuncture and the patient has clenched the fist. And when you're clenching the fist, the muscles, they get contracted, right? And there will be release of potassium into the circulation, right? So potassium release from the muscles with clenching of the fist. So this is other source of the pseudo hyperkalemia, right? This is other source of pseudo hyperkalemia. Now, for suppose, whenever you are suspecting pseudo hyperkalemia, then what will be the next step? What is the next step when pseudo hyperkalemia is suspected? Please tell me, what will you do? What will you do if you are suspecting a pseudo hyperkalemia? What you have to do is you have to repeat the blood sample. Right? So you need to do a repeat testing if you are suspecting pseudo hyperkalemia. Right? Next. Now, I said you there are two important causes, two important etiologies which will cause hyperkalemia. One is your transcellular shift, and the other one is impaired excretion of potassium by the kidney. Now, coming on to the transcellular shift. Right, coming on to the transcellular shift. That means what are the conditions or what are the etiologies which will cause the transcellular shift? The etiologies which will cause transcellular shift include acidosis. I'll explain you. Please tell me what is the normal pH? Any one of you? What is the normal pH of an individual? Yes. Yeah. So the normal value is 7.36 to 7.44. That is a normal pH, 7.36 to 7.44. So acidosis will cause transcellular shift. How it will cause transcellular shift? Mechanism I will tell you, right? And rhabdomyolysis will cause transcellular shift. Then tumor lysis syndrome will cause transcellular shift. Then drugs will cause transcellular shift. Then blood transfusions. So all the mechanisms I'll explain you now. So these are all the conditions where you will have transcellular shift. Now, let me explain you about the acidosis. Right, let me explain you about acidosis, how it will cause the transcellular shift. Now, first coming on to the acidosis. Now, if you take a cell, right, if you take a cell, the cell membrane, it contains what is called as, right, the cell membrane, it contains hydrogen potassium ions or channel, right? And what is the function of this particular hydrogen potassium channel? This is the one, this membrane pump, it will move the potassium into the cell. That is what is the function of this hydrogen potassium channel, which is present in the cell membrane. Now, whenever there is acidosis, that means there is more and more H plus ion outside the cell. Right? There is more and more H plus ion outside the cell. Now, when more and more H plus ions are present outside the cell, what will happen? This H plus ions, right? These H plus ions will try to move through this particular hydrogen potassium pump channel rather than the potassium moving inside. So it will be a competition between H plus ion and as well as K plus ion. So through this channel, whenever there is acidosis, the H plus ions will enter into the cell rather than potassium. So potassium will remain outside the cell, resulting in the hyperkalemia. That is the mechanism by which how acidosis will cause the hyperkalemia. So acidosis is one of the etiology which will cause the transcellular shift. Now, followed by the acidosis, I hope everyone has understood the mechanism of acidosis. Yes, please tell me acidosis, how it will cause hyperkalemia. All of you, have you understood or not? Right. Now coming on to the tumor lysis syndrome. Please tell me one particular etiology which will cause the tumor lysis syndrome. One particular etiology causing tumor lysis syndrome. Right, very good, Vishnu. Induction chemotherapy, like mainly the most common tumors, right? The most common tumors which undergo tumor lysis syndrome are non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma, after initiation of cytotoxic therapy, right? Non-Hodgkin's lymphoma, after initiation of cytotoxic therapy, that is nothing but chemotherapy. This chemotherapy will kill or will cause the lysis of the tumor cells. And whatever the content is present in the cell is released into the circulation. That means what all will be released into the circulation? Potassium will be released into the circulation, right? Phosphate will be released into the circulation, resulting in hyperphosphatemia. Uric acid will be released into the circulation, resulting in hyperuricemia, right? And this increased phosphate will combine with calcium, right? This increased phosphate will combine with calcium, resulting in what is called hypocalcemia, right? Resulting in hypocalcemia. So that is about the tumor lysis syndrome causing hypocalcemia, right? That is about tumor lysis syndrome causing hypocalcemia. Okay. So in tumor lysis syndrome, you will have hyperkalemia as well. And that is another etiology which will cause the transcellular shift. And apart from the tumor lysis syndrome, we have the drugs causing the transcellular shift. Drugs causing transcellular shift, that includes the digitalis or digoxin. Please tell me the therapeutic uses of digoxin. Any one of you? Please tell me therapeutic uses of digoxin. Very good. So used in the treatment of heart failure. That's all. Yes, Vishnu, very good, Vishnu. Atrial fibrillation, very good, Sangeeta. Even it is used in the treatment of atrial fibrillation. So these are the two important therapeutic uses. Lakshmi Priya, tumor lysis syndrome, you will not have hypercalcemia, you will have hypocalcemia, right? You will have hypocalcemia. Why hypocalcemia? Because the phosphate which is released from the cell will combine with calcium, and thereby the calcium is precipitated in the form of calcium phosphate. So the ionic calcium decreases, resulting in hypocalcemia, not hypercalcemia. Yes, Lakshmi Priya, is that clear? Right. Now, you take the drugs causing the transcellular shift, that is digoxin. See, we have a channel called sodium potassium ATPase. What is the function of this particular sodium potassium ATPase? It will send 3 sodiums out and 2 potassiums in. Right? 3 sodiums out and 2 potassiums in. That is what is the function of the sodium potassium ATPase channel. Right? Now, what your digoxin will do? Right? What your digoxin will do? Digoxin will block that particular sodium potassium ATPase channel. Thereby, digoxin, what it will do? The potassium which has to enter into the cell will not enter into the cell, and that will result in hyperkalemia. Right? The potassium which has to enter into the cell will not enter into the cell, and that will result in hyperkalemia. Now, always remember, mainly in case of acute intoxication of digoxin, in acute overdose, you have this hyperkalemia, not in case of chronic intoxication. Only in case of acute intoxication, you have this particular hyperkalemia problem with the digoxin, but not in case of chronic. So one particular drug which will cause the transcellular shift is digoxin. Now, can anyone tell me one particular ultra short acting skeletal muscle relaxant which will cause the transcellular shift? Ultra short acting skeletal muscle relaxant or neuromuscular blocker. So what is that? Very good, Vishnu. Excellent, Vishnu. Super, Parthiban. So the answer is the succinylcholine. Succinylcholine, you know, it is an ultra short acting neuromuscular blocking agent. What it will do? The same story. The mechanism of the mechanism by which it will cause hyperkalemia is similar to that of digoxin. That means what it will do is it will inhibit the membrane sodium potassium exchange pump. Right? It will inhibit the membrane sodium potassium exchange pump, and that will result in hyperkalemia. Actually, the sodium potassium exchange pump, what it will do, it will send the potassium from extracellular to the intracellular compartment. That is what is the function of sodium potassium exchange pump. But what this succinylcholine will do, succinylcholine will block that particular pump, and thereby the potassium is not secreted into the cell, resulting in hyperkalemia. Right? Now, having said this, so you see the summary. Right. So now the drugs that promote hyperkalemia, the one which will promote transcellular shift is digoxin, then succinylcholine, and we also have beta blockers. Please tell me the examples of short-acting beta blockers. Examples of short-acting beta blockers. Short-acting beta blockers. Okay, very good. Esmolol. Next, short-acting beta blockers, which we give in the treatment of bronchial asthma. Sorry, we give beta agonists, right? So, no, salbutamol and as well as salbutamol, is it a beta blocker, Vishnu? Right, it is a beta, right? Yes, it's a beta agonist, right? So esmolol, it is a short-acting beta blocker. Okay, right. Now you take the impaired, the etiology is causing impaired renal potassium excretion. So please tell me, what are the antihypertensives which will cause the adverse effect as dry cough? Please tell me, what are the antihypertensives which will cause, very good. So AC inhibitors. So AC inhibitors, what they will do, they will inhibit the RAS mechanism. Right, they will inhibit the RAS mechanism. So once they inhibit the RAS mechanism, that is renin-angiotensin-aldosterone system, aldosterone is not formed. When aldosterone is not formed, potassium excretion does not occur. And same story is even with your angiotensin receptor blockers. Right, same story is with your angiotensin receptor blockers. Please tell me a group of diuretic which will inhibit cardiac remodeling in congestive heart failure. Please tell me a group of diuretic which will inhibit the cardiac remodeling in congestive heart failure. Very good, Vishnu. So spironolactone, even spironolactone, what is the mechanism of spironolactone? It's an aldosterone antagonist. So thereby it will antagonize the action of aldosterone. So thereby potassium excretion does not occur if the aldosterone is antagonized. Then please tell me the drugs which will cause pre-renal type of acute renal failure apart from ACE inhibitors and ARBs. Please tell me the drugs which will cause pre-renal type of acute renal failure. Very good, Sangeeta. NSAIDs. NSAIDs are also the one which are responsible for impaired renal excretion because they will cause pre-renal type of acute renal failure. And the other drugs are heparin. Right? Other drugs are heparin. And one more drug we have which will cause impaired renal potassium excretion is, what is the drug of choice in case of PCP pneumonia? Drug of choice in case of pneumocystis jirovecii pneumonia. Very good. That is cotrimoxazole, which is nothing but trimethoprim sulfamethoxazole. Right? Trimethoprim sulfamethoxazole. Even this also causes impaired renal excretion. Right? Even this causes impaired renal excretion. Okay. So these are the etiologies. I mean, these are the drugs that will promote the hyperkalemia. That will promote the hyperkalemia. Mechanism and all we have discussed in detail. See, very simple. ACE inhibitors and ARBs and spironolactone. All these three drugs. Right? These three drugs, what they do? They antagonize the effect of aldosterone. And you take this particular NSAIDs. Right? And what these particular NSAIDs will do? These NSAIDs will cause pre-renal type of acute renal failure. That means they will reduce the perfusion to the kidney. So even the potassium which is coming to the kidney also will be reduced. And that will cause impaired renal potassium excretion. And another important etiology which will cause, yes, Another important etiology which will cause impaired renal excretion is adrenal insufficiency. Please tell me, what do you call that endocrine condition where you have adrenal insufficiency? Please tell me the endocrine condition which will cause impaired renal excretion. Sorry. Tell me the endocrine condition where you have adrenal insufficiency. That is nothing but Addison's. Right? Addison's disease. So in case of Addison's disease, there is a decrease in the aldosterone levels. Right? There is a decrease in the aldosterone levels. So once there is a decrease in aldosterone levels, the potassium excretion does not occur. Right? Potassium excretion does not occur whenever there is hypoaldosteronism. Right? Potassium excretion does not occur. Okay, right. Now, and so that these are the etiologies which will cause impaired renal excretion. Having said this, the other important etiology is blood transfusion, massive blood transfusion. Now you need to know how this massive blood transfusion will cause the hyperkalemia. See, the temperature at which the RBC are being stored are at around 4 degrees centigrade. Okay, so at 4 degrees centigrade, what happens is sodium potassium exchanger, whatever is there in the membrane, right? Sodium potassium exchanger, whatever is there within the RBC membrane, this will be shut off. And what is the function of this particular exchanger? It will send 3 potassiums out and 2 potassiums in. That is the function of this particular sodium potassium exchanger. Now at 4 degrees centigrade, this particular exchanger is shut off. Thereby what will happen? The potassium entry into the cell does not occur. Now in this blood, in the stored blood, it contains excess amount of potassium. And when massive blood transfusion is being done, it is like you are infusing RBC along with excess amount of potassium which is present outside the cell. So that is the mechanism by which massive blood transfusion will cause the hyperkalemia. Next, the another etiology where you will have this hyperkalemia is, we have a clinical entity called cotopyriophagia. What is this cotopyriophagia? There was some cases which are being reported. See, this matchstick, once it is being burnt, it is rich in potassium chlorate. Right? This matchstick, whichever is burnt, it is rich in the potassium chlorate. Now, there was a report, right? In 1985, a case report was published describing the patient with severe hyperkalemia, right? Describing the patient with severe hyperkalemia who was discovered to be ingesting 1500 burnt matchsticks. Now, what was the cause for hyperkalemia in that individual? Because he has consumed the burnt matchstick. And what is the terminology we use for consumption of non-nutritive material, that is pica? See, this pica you will come across even in case of anemia as well. Which type of anemia you will have pica? In which type of anemia? Very good, Vishnu. So it is in case of iron deficiency anemia. In iron deficiency anemia, you have this particular pica, and consumption of this burnt matchstick is also called pica. So that terminology which has been given here, it is called photopyriophagia, which will cause hyperkalemia, okay, which is nothing but consumption of burnt matchsticks. Now we have a congenital disorder that is called a Gordon syndrome. Is also the one which is responsible for the hyperkalemia. See, you take the normal distal convoluted tubule. What it will do, the principal cells contain the receptors for aldosterone. Can anyone tell me what is the name of the channel on which the aldosterone act? Yes, what is the name of the channel on which this particular aldosterone act? Very good, Varshini Jayaprakash, excellent. No one has answered, only Varshini has answered. Very good, Varshini. That is nothing but epithelial sodium channels, right? Epithelial sodium channels on which the aldosterone will act. And what is the function of this particular epithelial sodium channels? The function of this epithelial sodium channels is it will cause sodium reabsorption and then the potassium excretion, right? Sodium reabsorption and then the potassium excretion. That is the function of the epithelial sodium channels, right? That is a function of the epithelial sodium channels, okay? Now, that is what will happen in the normal DCT. The sodium is reabsorbed and potassium is secreted. But in patients with the Gordon syndrome, the potassium secretion is blocked, right? The potassium secretion is blocked. So as the potassium secretion is blocked, that will result in hyperkalemia, right? That will result in hyperkalemia. And this is what is nothing but your Gordon syndrome. Okay, so these are all the etiologies which will cause the hyperkalemia. So we will just summarize. We will just summarize because we have discussed many etiologies. We will just summarize. Please tell me, how do you summarize the etiology of hyperkalemia? What are those two important etiologies? What are those two important etiologies? Yes. Number one, very good. One is transcellular shift and the other one is impaired renal excretion of potassium. If there is impaired renal excretion of potassium, what will be urinary potassium levels? If there is impaired renal excretion of potassium, what will be the urinary potassium levels? Urinary potassium levels will be low, that is less than 30 milliequivalents per liter. And if it is transcellular shift, the urine potassium will be more than 30 milliequivalents per liter. Please tell me, what are the drugs which will cause the transcellular shift? What are the drugs which will cause the transcellular shift? Digoxin, then succinylcholine, then beta blockers, right? Succinylcholine and then beta blockers. So these are the drugs which will cause the transcellular shift, okay? Right. And what are the drugs which will cause impaired renal excretion of potassium? What are the drugs? ACE inhibitors, angiotensin receptor blockers, then NSAIDs, aldosterone antagonists like spironolactone, and two more drugs, heparin, one more apurva, one more Sindhuja. Very good, Lakshmi Priya, that is cotrimoxazole, that is trimethoprim and as well as sulfamethoxazole. So these are the drugs which will cause impairment of renal excretion of potassium. Now please tell me, how does a massive blood transfusion cause hyperkalemia? How does a massive blood transfusion will cause hyperkalemia? Yes, anyone? Yes, so yes, the sodium potassium exchanger, it will get shut off at a temperature of 4 degrees centigrade, and that is the one which is responsible for the hyperkalemia. Now, what will be the clinical consequences? I said you, the problem in these individuals will be the diastolic arrest. So whenever there is hyperkalemia, see, there will be, right, whenever there is hyperkalemia, there is slow or there will be slowed impulse transmission. Right, there will be slowed impulse transmission where in the heart. Right, and this slowed impulse transmission in the heart will progress to heart block. Right, will progress to heart block and cardiac arrest. Right, will progress to heart block and cardiac arrest. So that will be the clinical consequence. See, why are we studying the hyperkalemia? Why are we just going through the etiologies of hyperkalemia? The reason is all this. Right, I'll tell you the mechanism also. Why there will be slowed impulse transmission, the mechanism also I'll try and explain. See, now you take this is the depolarization of the cell, and then I'm talking about the cardiac cell, cardiac muscle fiber, right? Depolarization, that is your phase 0. Then you have phase 1, then phase 2, phase 3, and then phase 4. Okay, you take phase 0. Why does this phase 0 occurs? Phase 0 in the cardiac muscle cell is due to sodium entry, right? And phase 1, right? Phase 1 is due to what? It is due to potassium exit, right? And phase 2, it is due to calcium entry, which we call it as the plateau phase. And phase 3 is again potassium exit. Right, it is again the potassium exit. Which one? The phase 3. Now you tell me now, I'll ask you a question. In case of hyperkalemia, there is excess amount of potassium outside the cell. When there is excess amount of potassium outside the cell, the potassium from the intracellular compartment, will it go to the extracellular compartment? Potassium from the intracellular compartment, will it go to the extracellular compartment? The answer is no. Right? The answer is no. Okay. So thereby, the potassium exit is occurring. That means your phase 1 and phase 3 will be very, very slow. Right? Your phase 1 and phase 3 is very slow. And that is the reason why you have a slowed impulse transmission resulting in the heart block and as well as cardiac arrest. That is the mechanism by which the individual will land up in diastolic arrest in patients in clinical scenarios of the hyperkalemia. Now, how will you diagnose this hyperkalemia? One is your blood investigation. The other important investigation is the ECG. So I hope everyone has understood the mechanism of hyperkalemia causing diastolic arrest. Yes, all of you, have you understood the mechanism by which the hyperkalemia causing diastolic arrest? Right. Now, you take the ECG changes. What will be the earliest ECG change? The earliest ECG change, yes, Hari Prashant. 1 second, Hari Prashant, I'll explain you once again. Tall T waves. Right, that will be the earliest ECG change. Okay, and that too, these particular T waves, they are tall, tented T waves. What are the other conditions where you have tall T waves? What are the other conditions where you have? Yes, so the other tall T waves, you have that in case of MI. But here, right, but here in case of MI, that is myocardial infarction, you have like this, broad tall T waves. Right, broad tall T waves. Okay, so that is about the earliest change in the ECG in hyperkalemia. Next. Now, what are the other ECG changes? One is your tall T wave, that too a tall tented T wave. Then the another important ECG change will be the PQRST complex, right? PQRST complex. So the PR interval prolongs. When PR interval prolongs, what do we call this as? We call this as the first degree heart block. And as the severity progresses, there will be widening. What is a normal PR interval? What is a normal PR interval? How much is a normal PR interval? Very good, Vishnu. The normal PR interval is 120 to 200 milliseconds. And how much is the normal QRS complex, Vishnu? Right, the normal QRS complex. Yes, very good, Vishnu. It is around 70 to 100 milliseconds. Right, duration of normal QRS complex is 70 to 100 milliseconds. Okay, and subsequently, you will have absence of P wave. And finally, there will be ventricular fibrillation and then asystole. Right, subsequently, there will be ventricular fibrillation and asystole. So that is about, right, these are the ECG changes in hyperkalemia. These are the ECG changes in hyperkalemia. Tall T waves, PR interval being widened, QRS complex being widened, absent P wave, and then asystole. These are the ECG changes in hyperkalemia, right? Now, coming on to, yes, Hari Prashant was asking me about to explain the mechanism of diastolic arrest. I'll just tell you briefly. Okay, see, in case of the action potential, phase 0 of action potential is due to sodium entry. Phase 1 is due to potassium exit. And phase 2 is due to calcium entry. And phase 3 is due to potassium exit. That is the normal action potential of the cardiac muscle fiber. Now, you have to understand that, or you have to know that whenever there is hyperkalemia, right? Whenever there is hyperkalemia, the potassium exit does not occur with the normal pace. Potassium exit will be very slow. Why? Because there is more potassium outside the cell. When the potassium exit occurs slowly, even the action potential occurs slowly. Thereby, there will be a slowed impulse transmission. And because of this slowed impulse transmission, the individual will progress to the development of heart block. That is a mechanism of the diastolic arrest in case of hyperkalemia. Right? Yes, Hari Prashant, have you understood this? Okay. Now, after having discussed about the ECG, now coming on to management of hyperkalemia, right? Treatment of hyperkalemia. How do you treat this hyperkalemia? See, first and foremost, what we are very much worried is you need to antagonize the cardiac effects of hyperkalemia. Right? You need to antagonize the cardiac effects of hyperkalemia. That is one thing. Second important thing is you need to do a transcellular shift of potassium. Whatever is the potassium outside the cell, you have to shift the potassium into the cell. And third is removal of excess potassium from the body. right? Removal of excess potassium from the body. Okay, so this is how you need to manage the severe hyperkalemia. So if anyone asks you what is the drug of choice? Drug of choice for hyperkalemia, can anyone answer? What is the drug of choice for hyperkalemia? Very good, Vishnu. So drug of choice for hyperkalemia is that you need to give the calcium gluconate. Right, so three main goals are very, very important. What are those three main goals? Antagonizing the cardiac effects of hyperkalemia, transcellular shift of potassium into the cell, removal of excess potassium from the body. Now, you need to know the methods used to achieve. Okay, let me discuss one by one. That is membrane antagonism. Right, membrane antagonism. So how do you achieve this membrane antagonism? That is by calcium gluconate. Do you have any other alternative apart from calcium gluconate? The other alternative for membrane antagonism is the calcium chloride. Right, I don't know how many of you know this. If you're not knowing, right, early in the morning, I'm giving you a very, very important note. Apart from calcium gluconate, the other drug like what we have is the calcium chloride. Okay, right. Now, what is the mechanism of action of this calcium gluconate? What this calcium will do? Calcium, it increases the electrical charge difference, right? Electrical charge difference across myocardial cell membrane. Okay, so basically what the calcium will do is the calcium, it will increase the activity of the myocardial cell, right? Will increase the activity of the myocardial cell. And hyperkalemia is a life-threatening condition, and you require a quick response, right? You require a quick response. What is the duration of the response? So let me tell you, the onset of response will be within 1 to 2 minutes, and the duration of response will be for nearly around 20 to 30 minutes. But please remember, calcium gluconate, right? Calcium gluconate will not reduce potassium, right? It will not reduce the potassium. It will just only antagonize. It will just only antagonize the ventricular fibrillation. It will stabilize the cardiac cell membrane. It will increase the cardiac cell activity. That is what is the function of the calcium gluconate. Now, for suppose, what is the role of calcium chloride? When will you give calcium chloride? You have to give calcium chloride, right? You have to give this particular calcium chloride when the individual is in a state of cardiogenic shock. Right, when the individual is in a state of cardiogenic shock, we give this particular calcium chloride. Okay, so that is about the drug of choice for hyperkalemia. Right, so the same question is here. What is the indication of the calcium chloride? The indication of the calcium chloride is when the hyperkalemia, when it is associated with circulatory shock, or when the hyperkalemia is causing cardiac arrest. That is the point when we give the calcium chloride, right? How much of the calcium chloride we give? 10% calcium chloride we give. 10% of 10 ml calcium chloride is being given. Okay, so now these are, that is the drug of choice. Then you need to know what are the drugs which will cause the transcellular shift. The drugs which will cause transcellular shift is the insulin and as well as dextrose, right? Insulin and as well as dextrose. What this insulin dextrose will do, it will drive the potassium into the cell. It will drive the potassium into the cell, particularly in the skeletal muscle cell, right? Particularly in the, what is the mechanism? The mechanism is it will activate, right? It will activate the sodium potassium exchanger. Right? It will activate the sodium potassium exchanger. So what this insulin dextrose will do is the sodium potassium exchanger which is present within the cell. What does this sodium potassium exchanger will do? This sodium potassium exchanger, it will cause 3 sodiums out, 2 potassiums in. That is what is the function of this sodium potassium exchanger. And this insulin dextrose will activate this particular sodium potassium exchanger. Okay. Now the question is, why dextrose has to be given? Actually, the function of activating sodium potassium exchanger is by your insulin. Then why is this dextrose infused? See, whenever you are giving insulin, there is risk of hypoglycemia. So in order to reduce that risk of hypoglycemia, you need to give dextrose, right? You need to give dextrose. And the other drugs which will cause the transcellular shift will be the beta-2 agonist. Now, what is the mechanism of action of the beta-2 agonist? See, the beta-2 agonist that we give is the albuterol, that is short-acting beta-2 agonist, right, which is nothing but salbutamol. And this albuterol, what it will do, the mechanism is same. We give through this inhalational route. Okay, and this albuterol will also cause the drop in the serum potassium levels, right? This will also cause drop in the serum potassium levels. Okay, next. So this is about your drugs causing transcellular shift, insulin dextrose, and the other one is beta-2 agonist. Now, the third mechanism by which you can treat hyperkalemia is the potassium removal. Now, how is that you will achieve, or how is that you will do the potassium removal? See, we have drugs which will cause potassium removal, right? That is cation exchange resin. And the other methods by which you can do potassium removal is hemodialysis, right? Hemodialysis. Okay, so these are the two methods by which you can do removal of the potassium. Drugs, that is cation exchange resin, and second is your hemodialysis. Now, coming on to the cation exchange resin. Right, coming on to the cation exchange resin. The cation exchange resin include sodium polystyrene sulfonate. Right, sodium polystyrene sulfonate. This will be the multiple choice question for you. Sodium polystyrene sulfonate. What this sodium polystyrene sulfonate will do? This will exchange, it's an exchange resin. This will exchange potassium with sodium. That means sodium is reabsorbed, potassium is secreted. Right? Sodium is reabsorbed, potassium is secreted. That is what is your mechanism of action of the sodium polystyrene sulfonate. And the last mechanism by which you can do the removal of the potassium is your hemodialysis. So when will you do hemodialysis? Medically refractory condition, right? Refractory conditions, we do this particular hemodialysis. And when you do hemodialysis for 1 hour, the potassium will reduce by 1 milliequivalent. And if you do hemodialysis for 3 hours, you can reduce the potassium by 2 milliequivalents per liter. Right? You reduce the potassium by 1 hour. I mean, you do hemodialysis for 1 hour, you will reduce the potassium by 1 milliequivalent. And you do hemodialysis for 3 hours, you will reduce the potassium by 2 milliequivalents per liter. Right? So that is what is your hemodialysis. That is a mechanism. I mean, that is a method by which you can do potassium removal. So three treatment strategies. 1, membrane antagonism by calcium chloride or calcium gluconate. 2, the drugs which will cause transcellular shift, that is insulin dextrose and as well as beta-2 agonist. And 3, that is the potassium removal, that is your sodium polystyrene sulfonate and as well as the hemodialysis. And the other thing is even bicarbonate should be given. What is the purpose of giving bicarbonate? That is, it will mainly reduce the acidosis, because we have discussed that even acidosis is responsible for your hyperkalemia. Okay, now we will take up the multiple choice questions. Right, we will take up the multiple choice questions. Hyperkalemia, best immediate management of hyperkalemia includes all except. Very good, Prakalya. The answer is magnesium sulfate. Right, there is no role of magnesium sulfate in the treatment of the hyperkalemia. All are used in the management of hyperkalemia except. Very good. So many of the students, they get confused between beta-2 agonist and beta-2 antagonist. What we give is beta-2 agonist, not the beta-2 antagonist. Please remember, it's a very important point. Okay, next. Yes. So we have a 1-year-old male child having heart rate of 40 beats per minute. Blood pressure is 90/60. Serum potassium is 6.5. What is the next best management in this patient? Very good. So you have to give the calcium chloride. Why calcium chloride? Why calcium chloride? Because the individual is in a state of a cardiogenic shock, right? And the individual is also having bradycardia and going into a state of cardiac arrest. So where we give this particular calcium chloride. Next. What is not recommended in the management of hyperkalemia? What is not recommended in the management of hyperkalemia? See, loop diuretics like furosemide will cause the potassium excretion. Even loop diuretics are indicated in the treatment of hyperkalemia. Even you take any form of dialysis, either you take peritoneal dialysis or hemodialysis, that will cause potassium excretion. So Vishnu has answered first. Very good, Vishnu. 50% dextrose with insulin, not with water. 50% dextrose in water will further precipitate hyperkalemia. Okay, so the answer is D. Okay, 50% dextrose in water should not be given in the treatment of hyperkalemia. That will further precipitate the hyperkalemia. Right, next. Yeah, which of the following is the most serious side effect with sodium polystyrene sulfonate? This is a very, very important question. Yes. No, it doesn't cause any rebound hyperkalemia. What it will do is it will cause the intestinal perforation. Right, it is the one which will cause intestinal perforation. And how much is the dose of the sodium polystyrene sulfonate? The dose is around 15 to 30 grams, not even milligrams. It is 15 to 30 grams, which should be mixed with water and has to be taken. Okay, and the effect of this sodium polystyrene sulfonate, the onset of action is slow, but the full effect of sodium polystyrene sulfonate will occur by 24 hours. By 24 hours. Okay. And intestinal necrosis. This is the most serious complication with sodium polystyrene sulfonate. Okay. Next. Rebound hyperkalemia, cardiac arrest, not even the respiratory arrest. It is your intestinal perforation. Yeah, this is an interesting and very important question. Sine wave pattern on ECG is done or is seen when serum potassium levels are. Very good, Prakalya. The answer is 8 milliequivalents per liter. Right, the answer is 8 milliequivalents per liter. So when serum potassium levels are more than 8 milliequivalent per liter, that is the point when you'll have sine wave pattern. Now, Prakalya, can you tell me what do you mean by sine wave pattern? What do you mean by the sine wave pattern? Yes, what do you mean by sine wave pattern? Sine wave pattern is that where you have absence of the P wave. And you have a wide QRS complex. Right, so let me show you that. Sine wave pattern, right? You see that in case of very severe hyperkalemia, that is when the serum potassium levels are more than 8 milliequivalents per liter. That is the point when you will have this particular sine wave pattern. Just give me 1 minute. I'm opening that ECG part. I'll show you all the changes. I mean, already I have taught you this, but let me, yes. This is your sine wave pattern. You see, there is absence of the P wave. P wave is not there. QRS complex is wide and you have tall T wave. This is what is nothing but your sine wave pattern. Okay, seen in patients with hyperkalemia when the serum potassium levels are more than 8 milliequivalents per liter. Next. Yeah. Very interesting question. Decreased dietary intake of potassium is incriminated in all of the following except. Yes. Decreased dietary intake of potassium is incriminated in all of the following except. See, everyone is aware of what is called as DASH diet. DASH diet is the one which is rich in potassium. DASH diet is taken in patients who are having hypertension. So when there is a decreased dietary intake of potassium, hypertension will develop, stroke will develop, and congestive heart failure will develop, but not diabetes mellitus, right? Very good. Raghupati has answered. Very good, Raghupati. So the answer is D. Diabetes mellitus will not be seen. Next. Yes, you see another interesting question. Hyperkalemia is caused due to all of the following except. Hyperkalemia is caused due to, very good, Prakalya. So alkalosis will not cause hyperkalemia. It is acidosis which will cause the hyperkalemia. Okay, next. Another very interesting question. Very, very interesting question. Most rapid way of lowering potassium. Most rapid way of lowering potassium. Yes. No, Lakshmi Priya, Srinivas Balaji, what did I tell you? Calcium gluconate will not reduce the potassium levels. Calcium gluconate will just only antagonize the cardiac effect. That is what you have to remember. It is your, Raghupati has answered. Very good, Raghupati. So it is your insulin drip That is the rapid way of lowering the potassium by activating the sodium potassium exchanger. Okay. Please remember, calcium gluconate will not reduce the potassium. Very, very important point. Yeah. Hyperkalemia presents with all except periodic paralysis, hemodynamic collapse, ileus, slow idioventricular rhythms. Hyperkalemia, very good. Who is that? Vishnu. Very good, Vishnu. So ileus will not be there in case of hyperkalemia. Where will you have this particular ileus? You will have that in hypokalemia. You will have that in hypokalemia. So hypokalemia, you have the ileus, but not in case of the hyperkalemia. Okay, next. Yeah, cardiac rhythm seen with hyperkalemia is all except cardiac rhythm seen with hyperkalemia is all except. Excellent, Prakalya, very good. The answer is Torsades de Pointes. Very good, Vishnu. So Torsades de Pointes, it is seen with hypokalemia, seen with hypomagnesemia, seen with hypocalcemia, but not hyperkalemia. With hyperkalemia, you can have all these. Sinus arrest can be there, sinus bradycardia can be there, and ventricular fibrillation can be there. And what is this Torsades de Pointes? It is the disorder where you have prolonged QT interval, which will progress to the development of polymorphic ventricular tachycardia, right? Which will progress to the development of polymorphic ventricular tachycardia. That is what is nothing but your Torsades de Pointes, right? Next. I think another 1 or 2 questions are there. Yeah. Which of the following genetic abnormalities is associated with the development of hyperkalemia? Last question. The answer is no. I did not get the correct answer from any one of you until now. Vishnu has answered. Very good, Vishnu. That is autosomal dominant polycystic kidney disease. See, autosomal dominant polycystic kidney disease, these patients, they will progress to the development of end-stage renal disease. So as these patients develop end-stage renal disease, that will cause hyperkalemia. That will cause hyperkalemia. So in all these, right, you will not have hyperkalemia. Right, in all these, you will not have hyperkalemia. In fact, in Liddle's and Gitelman's, there will be hypokalemia. In Liddle's and as well as Gitelman's, in fact, there will be hypokalemia, but not hyperkalemia. Okay, so the answer is D. So finally, what will be the take-home message from this class? What is that you have to learn from this class, right? I'll tell you some nutshell points, which are very, very important points of the session. Right. So the important points of the session is that, number 1, the plasma potassium is only the tip of the iceberg. Why? Because the entire potassium is present within the cell, not outside the cell. That is the reason why I'm calling it as tip of the iceberg. And potassium deficits are often larger than suspected, right? Potassium deficits are often larger than suspected in hypokalemia, even in mild cases. Acha, hypokalemia we did not come across. Okay, fine. So in this session, what all you have to learn from this session is the cause of death is diastolic arrest. The 2 important etiologies causing hyperkalemia will be transcellular shift and as well as impaired potassium excretion. Impaired excretion of potassium by the kidney. And the clinical features, there will be the heart block, bradycardia, and cardiac arrest. The diagnosis is by your serum levels of potassium and as well as ECG showing tall tented T waves, wide QRS complex, prolonged PR interval, sine wave pattern. Drug of choice will be calcium gluconate. If the individual is in cardiogenic shock, calcium chloride should be given. And the one which will cause rapid reduction of potassium is insulin dextrose drip. The other drugs are beta-2 agonist, and the one which will cause the potassium excretion is by loop diuretics, sodium polystyrene sulfonate, and in refractory cases, dialysis, right? So that completes the discussion of this topic of hyperkalemia. So I hope you have understood this particular topic thoroughly, and see you again day after tomorrow with the continuation of the disorders of the potassium, that is hypokalemia, right? So just please give me a quick feedback, like how was the class? I will send you the PDF. Please just give me a quick feedback, like how was the class? It will definitely help me. Yeah, Jervin, I will send you the PDF. I will send you the PDF. You can just go through in the PDF. Right, I hope you were able to follow the class. Right, okay. So, right. So thank you very much for your feedback. So your feedbacks, right? So your feedbacks are definitely very, very important for me, right? So this will give me the boost for the remaining part of the day, right? Yes, I will send you the notes also. I will send you the PDF notes. Right away, I will send to Dr. Arun, and Dr. Arun will be circulating that in the group, right? Thank you very much. See you again in the upcoming sessions.